Hello and welcome to this poster presentation on appendicitis, the most common indicator for emergency abdo surgery in the world. I'm Peter McComb.
And I'm Matt Dodsley.
And we have 10 minutes to get through everything, so we're going to dive right in. And Matt, what can you tell us about the epidemiology of appendicitis?
Okay, so the appendicitis is most common during the second and third decades of your life. According to results from D'Souza and Nugent's 2016 paper, in the US, the lifetime risk of developing appendicitis is 8.6% in men and 6.7% in women. An interesting piece of research from Rhine is that people with white skin are much more likely to suffer from an appendicitis, with 74%, compared to people with black skin, which is only 5%. The disease is not particularly well understood. The appendix is first noted in drawings by Da Vinci dating back to the 15th century, but until recently it was thought to be a vestigial organ, i.e. one that has lost its original function through evolution. However, in recent years theories have developed as to what the appendix actually does. One such theory is the safe house theory. This works on the principle that the appendix helps the gut recover after a gastro disease. The appendix contains a particular type of tissue associated with the lymphatic system, which carries white blood cells needed to fight the infection. These lymphatic cells encourage the growth of beneficial gut bacteria, which plays an important part in digestion and immunity. So basically what we're saying is that the appendix protects a collection of beneficial gut bacteria when certain diseases wipe them out from other areas of the GI tract and then releases them when needed. Moving down the game board, we get to the anatomy of the appendix. The appendix is a small finger-shaped pouch that is attached to a part of the large intestine called the cecum. It averages approximately 9 centimetres in length and has a thickness of between 2 and 3 millimetres. It is located in the lower right quadrant of the abdomen at a spot called McBurney's Point, which you can see on the poster if you look to the right hand side.
Yeah, so in the book Greenfield's Surgery, Mulholland et al. In 2017 state that the appendix is a true diverticulum of the cecum, meaning that is a hollow viscus. It's a fancy word for cavity, and it involves all the layers of the colonic wall, which you can see on the poster and the diagram just on the left hand side. It's made up of the mucosa, submucosa, muscularis and the serosa. A good study by Bouchard et al. In 1973, they detail that the orifice of the appendix opens up into the cecum and that the attachment to the cecum is constant. However, due to an incomplete rotation of the umbilical cord or umbilical loop during embryogenesis, when we're developing in the womb, in other words, it can land and settle variably from person to person. So why is that relevant? Well, when it comes to our physical examination of patients, such an anatomic variation can actually complicate our diagnosis, particularly in the pre-hospital environment of appendicitis. Because it results in the site of pain, and our findings from performing the clinical examination that will reflect the anatomic position of the appendix within the individual, which can vary widely between person to person.
According to Ross and Wilson, the cause and mechanism of an acute appendicitis is largely unknown. However, it's proposed to be due to the obstruction of the appendiceal lumen. This could be down to causes which we've listed on the poster. Predominant theories centre on luminal obstruction of the blind-ending appendix as a primary pathology. When goblet cell secretions are blocked from escaping by the luminal obstruction, the intraluminal pressure within the appendix increases and leads to ischemia of the appendix wall. The infection causes bacteria in the appendix to grow and the organ to fill with pus and swell. Due to the inside of the appendix being very small, there is little room for swelling, which in turn causes the pressure in the organ to increase, which results in perforation, resulting in a complicated appendix. This rupture of the appendix causes the contents to spread into the abdomen cavity, potentially infecting the peritoneum.
And in 1995, Temple et al. Done a study that showed that 20% of patients develop perforation of the appendix less than 24 hours after the onset of symptoms. 65% of patients where the appendix was perforated had those symptoms for longer than 48 hours. So looking at the history and the clinical features of appendicitis, there's just so many different conditions and symptoms that can mimic appendicitis, it can be very difficult to spot. Yet Seminole in 2019 tells us that usually patients complain of abdominal pain, periumbilical in nature, then migrating to the lower right quadrant as the inflammation progresses. However, Chung et al. In 2000 found that this migratory pain only occurs in 50 to 60% of patients.
Assessing the patient with abdominal pain in the pre-hospital setting, we'll go for our normal assessments tools listed on the poster. However, there are some extra assessments that have always been associated with appendicitis. Diagrams on the poster are given a simple explanation of how these are done and the relative sensitivities and specificities of these assessments are shown on the red part of the game board. According to Yale and Tekiner from 2022, however, the reliability of these assessments has not been well researched. Indeed, we ourselves were unable to find any results for the assessments of rebound tenderness, despite the fact that J.R. Calc states that it's indicative of an appendicitis. The study goes on to state that these assessments are often performed incorrectly and that this could provide or explain the wide sensitivity and specificities as listed on the poster. They do, however, argue that a positive test on these assessments could rule in a positive diagnosis, but a negative test can't rule out the appendicitis.
And now we come to the most difficult aspect of appendicitis, the diagnosis. With such a wide-ranging variation of infectious conditions and symptoms that can mimic appendicitis, we do have various screening tools that we can use within the hospital. These are known as the Alvarado and the Zanaki scoring systems, which are used to diagnose acute appendicitis. Now, these look mainly at the patient's signs and symptoms, but we don't use any of them as a definitive standard.
Yeah, and according to Junior and Brand, one of the drawbacks of these scales is that they fail to take into account both the age, the race, or the sex of the patient. As we've noted earlier, there's a big discrepancy between who is affected by appendicitis. So they claim that these factors being included into the scales could help diagnosis become more accurate.
Yeah, and talking about accuracy, ideally it's recommended across a number of texts that the CT scans should be used to assist with diagnosis. However, definitive diagnosis can really only be achieved by surgical exploration.
But I will say though, Peter, the problem with this is that according to Kabila, negative appendectomy rates are as high as 20%. So basically appendicitis is predominantly a clinical diagnosis and no single individual symptom or sign can be relied upon to diagnose or exclude.
And to consider a management and treatment plan for acute appendicitis, for over 100 years, open appendectomy was the only standard of treatment for it. However, in present times, contemporary management has become more sophisticated and nuanced. Laparoscopic appendectomy, known to you and I, Matt, as keyhole surgery, is now more popular than open surgery, although several trials have suggested that it is in fact feasible to treat uncomplicated appendicitis with just antibiotics.
Yeah, in a study from Becker in 2022, looking into patients treated with antibiotics as opposed to surgery, approximately 90% of the patients treated with the antibiotics were able to avoid surgery during this initial admission. The 10% that failed to respond required a rescue appendectomy. It then goes on to state that between 20 and 30% of these patients, non-operated, had the recurrence of an appendicitis in the following year. So even if we assume that these patients then had surgery, that still leaves 60% of patients who avoided the trauma and associated risks of surgery. Another benefit to the antibiotic approach is the reduction it brings in negative appendectomies, which, as we spoke about earlier, can be about 20%.
Well, Matt, I suppose we should really consider what the negatives of antibiotic treatment are. As you mentioned, there are the fairly high recurrent rates. The evidence you've produced shows that although the use of antibiotics can help reduce the number of appendectomies in uncomplicated appendicitis, when the appendix has become perforated and gangrenous, namely complicated appendicitis, it is unlikely to be cured by antibiotics. The antibiotic approach may not be favoured by everybody, with some people preferring the definitive of having the appendix removed with no risk of recurrent appendicitis. Another result of the decrease in the number of surgeries performed would be the significant rise in antibiotic use. We should really consider the antibiotic resistance. especially as some patient will probably need more than one course.
Yeah, okay. And moving on to pain management. Brewer and Rash's 2022 paper states that IV opioids are the primary analgesia used to control pain in patients with suspected appendicitis. However, this brings the obvious problems of addiction, as well as the issues of repeat dosages and having to monitor the patient in a crowded A&E department.
Yeah, those are pretty good points, Matt. But Brewer and Rash also say to us that there has been limited research into alternative analgesia. They also suggest the use of an ultrasound-guided erector spinny block injection that could be used. Although they state that early tests are promising, they do admit that further research is needed on this.